Good morning, everyone. Thank you for joining us on Friday at 8 a.m. It's my pleasure to introduce Dr. Daniel Lee today. He's a clinical professor of medicine at UC San Diego Health. He attended the UCSD School of Medicine to receive his MD degree at his internal medicine residence program at UCSD Medical Center and an HIV fellowship at the UCSD Owen Clinic. In 1999, he joined the Owen Clinic as faculty and has remained actively involved in HIV clinical care, clinical research, as well as teaching and mentoring UCSD medical students, residents, and fellows. Dr. Lee leads the Owen Lipid Lipodystrophy Clinic, which is a subspecialty clinic which started in 1999, focused on the clinical management of metabolic complications of antiretroviral therapy and comorbidities. Furthermore, he is a current principal investigator for the UCSD local partner of the Pacific AIDS Education Training Center, the board president of Being Alive San Diego, a local AIDS service organization, and a longtime committee member of the California-Hawaii chapter of the American Academy of HIV Medicine. Finally, he is passionate about teaching Kili meditation to patients, students, and medical providers of all levels to improve individual level wellness and reduce burnout. And today we will be hearing from Dan about the latest CROI findings. So please take it away. Thank
Great.
you.
Thanks, Anik. I'm usually tasked with reviewing the complications of HIV and been doing this for several years. It's, I guess, part of the penance for going to CROI. We have to present, but it's always my pleasure to do this. Um, so here are my disclosures. The learning objectives, what we're going to talk about today is a few of the different comorbidities. I have a few slides on talking about what's new in terms of hypertension and diabetes in people with HIV. There was a nice session on heart failure as well, and of course there are always some various talks on cardiovascular disease. Um, my area of interest is in a lot of the weight gain issues, and so we'll talk a little bit about what there were some switch studies that were presented and some studies related to some of the GLP-1s that I will review. And then I'm going to end, depending on how much time we have, on talking about what the current understanding of weight gain is in people with HIV. And there was an excellent overview that was done by Jordan Lake that I will go over and hopefully we'll have enough time to get through all of that. So that's the plan for today. So in terms of comorbidities in general, there was this nice study that was presented from a Spanish group, Alejandro Garcia, looking at health-related or age-related health outcomes in people living with HIV over an 18-year period. The cohort was called Chorus, and as you can see, started in 2006, but extended all the way to 2023. And their main outcome, in terms of looking at primary outcomes, was serious non-AIDS events. And the serious non-AIDS events were categorized into three kind of buckets. So major cardiovascular events, or MACE, non-AIDS defining malignancies, and non-accidental, non-AIDS related deaths. So that was the primary outcome. They also looked at a variety of secondary outcomes, which includes a lot of different, the usual standard comorbidities, hypertension, diabetes, chronic kidney disease, lipid issues, etc. And they also looked at what the comorbidity burden and the polypharmacy burden was over this 18 years in Spain. Um, so in terms of baseline characteristics, there are almost 19,000 antiretroviral naive participants included in this cohort. What you'll find interesting is that the median age is 35, which is pretty young, and so I think demographics are different. I think certainly in different countries, and in this cohort, a majority was male, so over 80%, and that was increasing throughout the study. Majority were MSM, and as you can see, the IDU population in terms of new people naive to care had really decreased significantly. Um, in terms of the prevalence of the serious non-AIDS events, actually decreased over the each of the 6 years, so from 3.4 to 2.6, 2.1%. I'll show you the more specific details of that in a sec. And in terms of the prevalence of secondary outcomes, it was pretty much the same throughout. And so this was the primary outcome, showing that MACE events here on the left, non-AIDS defining malignancies, and then deaths here on the right are all decreasing over time. Um, and I think that's not unexpected. I think that's kind of what we would see in other places as well too. What was interesting was that the secondary outcomes in terms of comorbidities did not necessarily increase. And if you look at all of these, they're a little bit across the board. Some go up, some go down, but essentially they're fairly flat. And perhaps that is just because this cohort is maybe a slightly younger cohort. I would think that in the US, if we were to do this, maybe you might see increasing comorbidities, but I think this really just has to do with who is getting diagnosed with HIV. And so, people perhaps younger are still the ones getting diagnosed. And so, over time, I would expect to see an increase in these, but at least this was kind of the data that was seen in Spain. When you look at the age of first onset of the serious non-AIDS event, you can see from the early to the mid to the late last 6 years, the age at the onset was higher. So, in other words, there's more of a delay in terms of the onset of the first uh, serious non-AIDS event. Uh, the age of the first secondary events in terms of the comorbidities did not show any difference, and that data isn't shown here. And lastly, when you look at the comorbidity burden here from the over the years, what you can see is that I would probably focus you on the darker colors. And what you can see is that maybe the darker colors, people are having more comorbidities over time. And so across the different time periods. And no surprise with that said, polypharmacy burden also increases as well with time. So maybe the darker bars here, certainly in the far right here, you can see is maybe increasing. So in terms of the polypharmacy prevalence is also higher. So bottom line, they found significant reductions in the incidence of serious non-AIDS events and delayed onset. So, in other words, we're doing a better job, I think, at perhaps getting people on therapy and preventing the incidence of these serious non-AIDS events. There was no differences seen in the incidence of secondary events, although I expect that with aging and people doing better, as people get older, we will see more of these comorbidities as well as polypharmacy over time. So we'll switch gears and very briefly talk a little bit about hypertension. And this was an interesting study using the co-opera cohort If you remember, the opera cohort is usually consists of people from all the AIDS healthcare foundations around the country, and it represents about 13% of the HIV population, at least here in the US. And so this was a study looking at people with HIV, about 10,000, who initiated or switched antiretroviral therapy with normal blood pressures at baseline less than 140 systolic, less than 90 diastolic, and was basically looking to see were there certain antiretroviral regimens that might be associated with incident hypertension, with the thought that perhaps with the weight gain, perhaps seen with dolutegravir or bictegravir, or perhaps with TAF regimens, that maybe you might see a trend towards higher hypertension in those populations. And so on the left here, we have naive population. On the right is an experienced population. And, if you look at the incident rate ratio, it's all hangs around zero and everything crosses zero. So bottom line was that there was nothing that was statistically significant showing a difference in regards to the incident hypertension. But with that said, I do think that the consequences of weight gain that we are seeing does lead to hypertension, and so it is something that I think we do have to obviously deal with as primary care providers working with our people with HIV. So I'm going to switch gears and talk very briefly about diabetes. And there was one interesting study that looked at the NA Accord and the IDEA cohorts, looking at incident diabetes among people switching from either an NNRTI or PI regimen. They had to be patients here in the US or in Canada, and people would either switch to an integrase inhibitor or they continued on the regimen. And people were followed up looking at the outcome of diabetes, which was defined as an A1C of greater than 6.5% or equal to that, being on a diabetes medication or having a diabetes diagnosis. And what you can see in the Kaplan-Meier curve on the top right here is that the people who switched to the integrase inhibitors are in this blue line. People who stayed on their non-nucleoside or protease inhibitors is in the red line. And you see that there is this kind of early separation that happens even before the end of the first year, suggesting that integrase inhibitors, maybe there is a slight increase in incident diabetes. But if you look beyond that first year period, it looks to be pretty flat and equal, similar to the NNRTI and PI group. When you actually look at what the incidence rates adjusted hazard ratio, I should say, when you looked at the switch group, there was maybe a 22% increased risk of diabetes in people who switched. However, when you looked at the specific integrase inhibitors, there was no significant difference that was necessarily seen. It's tough to say if whether or not this has to do with just kind of a low N. Although when you look at the number of people on these, there, 1,000 plus people on these regimens. So I think perhaps a little bit hard to say. And I see Nettie's comment, based on the single tablet regimens available, I'm guessing that many of the switches would have also been switching from TDF or TAF. And you're absolutely right. That is the case. I don't think that they actually did talk about that, however. And so I did not see anything, at least in regards to the breakdown between people switching from TDF or TAF. But of course that I think is an excellent point. And I think in some of the studies I'm going to be showing in the near future, they're going to actually look at kind of what regimens people were on before and afterwards. But in short, there have been other data looking at incident diabetes or prevalence of diabetes as well too. And there are some, few case reports of some pretty severe cases of diabetes soon after initiation of antiretroviral therapy. But I think those are fairly rare for the most part. But I think certainly with the weight gain that we can see with some of these agents, I think screening for diabetes is definitely imperative. And as our patients are getting older, I think that's very important for all of us to do. Um, All right. So I'm going to switch over to heart failure, and there was an excellent overview that was done by Matthew Feinstein, looking at heart failure phenotypes and what the etiologies are within the CNIX cohort. Uh, and uh, So this study, so what's the background? There is data to suggest that there is an elevated risk for heart failure in people with HIV. And so some studies have suggested a 1.5 to 2 times or higher elevation in heart failure risk in people with HIV. And I think clinically, as a primary care provider for our people with HIV, I will say that I have seen more heart failure, I think, in the last, I don't know, probably 5 years more than I had previously. But in part, I think it's because our patients are living longer as well. As to why that's the case, as you can see, it is quite complicated, and there are a variety of HIV related risk factors that can happen. There are a ton of different mechanisms that can lead to myocardial injury that are listed here. And as a result, there are a lot of different pre-heart failure phenotypes that can happen that ultimately lead to, as we call it, heart failure. So the main question is, well, what does heart failure look like in people with HIV, and why does it matter? And so what we do know is that the way heart failure is looked at these days, it is tailored by the presentation. So it can look at, categorizing people as either having heart failure with reduced ejection fraction or preserved ejection fraction, or sometimes heart failure is categorized based on the phenotype, whether it's infiltrative or if it's amyloid or due to other etiologies. And so understanding the phenotype and the suspected etiology helps us determine therapy as well as prognosis. But in terms of the data for people with HIV, we really don't have much on all of these. And so that's kind of the data that we need, and this is the data that was obtained through this study. And so this study was a study done by CNIX, and UCSD is one of the CNIX site. So the N in the database is over 49,000, and basically combed through the database, looked for presence of heart failure, looking at also what type of phenotype and etiologies. There was a central adjudication process that was done. This data is only looking at data from two sites, University of Washington and University of Alabama at Birmingham, and they're going to do the rest later on in end of this year or the middle of this year. So at least at those two universities, there were 9,600 people who were screened, about 402 that had possibly had heart failure, This was confirmed in 289. And then in terms of what was new episodes of heart failure, there's 212. There were also two cardiologists that were blinded to each other, and so the inter-rater agreement on heart failure presence was about 90%, which is pretty good. In terms of the key findings, I think not necessarily too surprising, but the traditional cardiovascular risk factors are the ones that lead to incident heart failure. So what you can see on the table on the right is age is a risk factor, having a prior history of cardiovascular disease or myocardial infarction, having hypertension. Here it says treated, but also having diabetes is a risk factor. And interestingly, a higher eGFR was actually protective. But I think we do also know that chronic kidney disease, the opposite, is a risk factor for heart disease and heart failure as well. So I think that makes sense. But then traditional HIV risk factors such as higher CD4, sorry, higher viral load and lower CD4, and that was also seen here on the table on the right. And the findings were similar, seen at both sites, and I suspect, it will be the same at all of the sites. In terms of the classifications of left ventricular ejection fraction, just to kind of reminder, there is heart failure, reduced ejection fraction, so our HFrEF, HFpEF, which is preserved ejection fraction, and then there is this MREF, so mid-range ejection fraction. And so in this study, the mean left ventricular ejection fraction was 42%. If you remember, normal is probably like probably 60% or so. Although here, I think the definition of preserved ejection fraction is greater than 50%. Reduced ejection fraction is defined as less than 40%, and this mid-range is between 40 and 50%. If you look at the classification by etiology, only 11% of these heart failures were felt to be ischemic, 17% mixed, but majority of them were in this non-ischemic category. And you can see the breakdown a little bit more. About 44% of this was hypertensive, but 31% was related to substance use, which was the most common non-ischemic sub-etiology. Interestingly, at UAB, it was mostly hypertension. At UW, it was mostly substance use. But when you compare to, global heart failure etiologies on the right here, you can see a whole bunch of different categories. I think the main thing is that in people with HIV, at least there tended to be less ischemic causes, but more substance use related causes. And in my experiences at the Owen Clinic, I would say that that seems to be the case as well too. I certainly have my share of meth, amphetamine induced, as well as even alcohol induced, heart failure. Um, So we'll move on to cardiovascular disease. And so there was an interesting study with the START study. So if you remember the START study, and I'll show you that in a second, but this study looked at basically whether or not there was a difference between early versus deferred antiretroviral therapy and cardiovascular disease in people on the START study. So just to remind you with the START study, this included people with HIV over the age of 18. They were antiretroviral naive with CD4 count greater than 500. So people randomized to either, well, actually not randomized, but they either received immediate antiretroviral therapy following randomization, or they were deferred antiretroviral therapy until their CD4 count declined to 350 or a diagnosis of AIDS developed. So in this study, it was a primary composite outcome looking at serious non-AIDS or AIDS, non-AIDS or AIDS events, including cardiovascular disease or death. So if you remember, the study was enrolled from 2009 to 2013, but in 2015, the immediate therapy resulted in a 57% risk reduction for the primary outcome, which led to stopping the study, and everyone was advised to then start antiretroviral therapy. And then this study looks subsequently, people were followed up through 2021. So at the time of the unblinding in 2015, the rates of cardiovascular disease were fairly low. So you can see the rates 0.17 per 100 person years versus 0.20 in the deferred arm, and the hazard ratio was 0.84 with a non-significant p-value. And so this study was looking at comparing the cardiovascular disease event rates between the immediate and deferred through the entire follow-up. The composite cardiovascular disease outcome included MIs, stroke, coronary artery disease requiring revascularization, as well as CVD-related death. And so comparisons of the treatment arm difference were done between the two different study periods, so pre-2016 and then post-2016, which basically is after the unblinding period. So keep in mind, this was a large study, 215 clinical sites across 35 countries, so a very heterogeneous population. It's important to keep in mind here the median age was 36, about a quarter female, about a third Black. Because this was international, I think the smoking rates were a bit higher, 32%. And when you look at the Framingham 10-year risk, about 1.9%. So these were, not super duper high risk people, but you do see, some hypertension, some lipids, some diabetes, but for the most part, pretty low. But, this is an international study, and statin use was about 2.3%. And so the time to first cardiovascular disease event in the entire study cohort from 2009 to 2021, you can see that there were a total of 35 CVD events in the immediate arm, 36 in the deferred arm. So essentially no real difference, and you can kind of see the Kaplan-Meier curve here, which essentially overlaps. And so bottom line, no differences were seen between the treatment groups. If you look, interestingly, so when you look at the cardiovascular disease events comparing pre-2016 versus post-2016, I think, maybe in the pre-2016, if you remember, there's half the group that were not on antiretroviral therapy. So maybe that pushes your median a little bit to the right. But then once everyone started antiretroviral therapy, what you see is that maybe it shifts a little bit to the left, suggesting that, treating uh, with antiretroviral therapy does help to perhaps reduce some of the cardiovascular risk and probably decreasing inflammation on some level, which makes things a little bit better. But there was no difference that was seen between these two time groups. However, what was seen, which was interesting, was that when you look at the difference between males and females, there was a difference that was seen in females. So that was the only group that had shown a difference with lower event rates in the immediate versus deferred arm in females, but not males. So they're caution here is that there was no adjustment necessarily made for multiple comparison, and the numbers are very low, as you can kind of see here, 2 in the immediate group and 11 in the deferred group. But this does, make it a bit interesting. When you actually looked at the CVD event components in terms of what made up of those cardiovascular disease rates, looking at males on the left, females on the right, what you'll see is that with the males, much more of the standard kind of MIs, coronary revascularization events. However, for the females, tended to be more strokes as the common event. And strokes occurred mostly among the females over the age of 50. And so it's a little bit challenging, a little bit tougher for me to say. I do not have that many females in my clinic these days, but I do wonder if this is something that is that other providers might agree with, that perhaps they see more strokes in females. What they also looked at is some of the baseline characteristics across sex at birth. And so there was a higher proportion of females that were over the age of 50 in this study, were Black, were from Africa, had higher body mass index, and were HIV positive for longer periods of time. When they looked at the men, they were more likely to be smokers, and more likely to have a higher Framingham score as well too. So bottom line, the interpretation was that CVD event rates were low overall in the START study. The median age was 36 with people with higher CD4 counts. Immediate antiretroviral initiation was not associated with reduced cardiovascular disease events, but perhaps this is a balance between reducing the risk with starting antiretroviral therapy versus maybe the risk of some of the antiretroviral therapies causing dyslipidemia, for instance. But the data did suggest that perhaps maybe there's a greater benefit specifically for females with immediate antiretroviral therapy. However, as we kind of pointed out, the numbers are actually on the small side. So there was also a study done by Steve Grinspoon, once again, looking at the Reprieve study, looking at plaque inflammation as well as subclinical myocardial injury and major adverse cardiovascular events in the Reprieve study. So just to kind of remind people, the Reprieve study is on the left here, very briefly summarized. So people with HIV on stable antiretroviral therapy with low to moderate risk of atherosclerotic cardiovascular disease that were placed on either pitavastatin versus placebo. And bottom line, the study was stopped early. There was a 36% reduction in the pitavastatin arm in major adverse cardiovascular events after 5.1 years. So this was a sub-analysis, so only 804 people. And in this sub-analysis population, age 51, 83% male, LDL of 105, and ASCVD score about 6.6%. And just as a reminder, starting statins, the recommendation is over 7.5%. So this study looked at the relationship of baseline factors with MACE as well as the modification of the statin effect. And what was found, in short, was that the non-calcified coronary plaque, markers of inflammation, as well as markers of subclinical myocardial injury, were all associated with a higher risk of MACE. And so to help remind people, non-calcified plaque is what can potentially break off and then cause a heart attack or stroke. So I don't think that that is necessarily surprising, at least, these kinds of findings. So certainly higher levels of inflammation as well as myocardial injury uh, would lead to increased risk of these. And so this is the actual data itself, kind of looking at non-calcified plaque here. So this is unadjusted, although when you look at even adjusted for ASCD CVD risk or risk score component adjusted, was still statistically significant. And so what you can see here, so non-calcified plaque, so the presence of plaque, hazard ratio was 2.5. Even if you look at, so they even broke down the number of segments of non-calcified plaque. They looked at even the volume of non-calcified plaque, as well as even looking at the coronary artery calcium scores as well too. However, once adjusted, that did not show that it was remained statistically significant. When you look at the biomarkers, specifically the standard ones, highly sensitive CRP, as well as IL-6, and also troponin T, also showed higher hazard ratios for MACE, and also even when adjusted. So I'm going to switch gears, just time check, 8:37, so I think we're good. So in terms of the weight gain studies, I'm going to talk first a little bit about switch studies, the few that were done, and then about some of the GLP related studies. And so the first one I'll just touch base on is Paso Doble, and I think that this has really gotten a lot of interest more recently. So the Paso Doble study was looking at a switch in people with suppressed viral load. This was done in Spain. So keep that in mind. People were on different antiretroviral regimens, but no current or prior integrase inhibitors. And kind of to Nettie's point, there was maybe about a third of people on TDF, and about 50% were on an NNRTI, primarily efavirenz. And so the reason this matters is because it does depend on kind of what regimen you're on. And so if you're on a TDF or efavirenz regimen, it probably doesn't matter really what you switch them out to, but as long as you don't have them in the regimen, people will probably gain weight on some level. But then here's the study schema in terms of this was a multi-center randomized open label phase 4 trial in Spain. So once again, people were on these regimens and people were either switched to the dolutegravir 3TC or the BIC F-TAF arm. And looking at the primary endpoint was viral load greater than 50 um, by snapshot, and then other secondary endpoints. I'm not going to focus a lot on any of the primary endpoints, but really focus just on weight. And what was seen in terms of weight, and this was presented at AIDS end of last year, but bottom line showed that people were switched to the BIC F-TAF arm ended up gaining more weight than the dolutegravir 3TC by a fair percentage. And so the question is, well, why is this necessarily the case? And so when you break down the data even further and looking at weight gain greater than 5% by pre-switch NRTI, and so once again, as I said, if you focus on the TDF, if people were on TDF pre-switch and then switch to BIC FTC TAF, they were actually the ones that had the most weight gain compared to the dolutegravir 3TC. Interestingly, you also saw that in people who were also on abacavir as well too. So it at least appeared that there was this difference between the BIC FTC TAF versus the dolutegravir 3TC arm. So not exactly still clear why that is the case, but I think this is just a reminder that we do need to keep in mind what people's regimen was prior to the switch. And so at CROI, there were two specific analyses that were looking at this data further. And I'm going to just I added this column here on the left called the pooled population, which included both people on the Dovato as well as the Biktarvy arm. And what was seen, at least in terms of weight, and you can kind of see it's a little bit hard, but you can, this looks at DEXA scan, so total mass, total fat mass, appendicular fat, so fat in the extremities, abdominal fat mass, visceral fat mass, total lean mass, so that's muscle, appendicular lean mass in the extremities, and then there's a CT looking at subcutaneous fat, SAT, or VAT, by abdominal CT. And I kind of highlighted or bolded the things that were interesting in the sense that in both, whether they were on the dolutegravir or the bictegravir arm, there was about a 21% increase in abdominal visceral fat across the board. When you look at subcutaneous fat, there was 0%. So this goes along with the thought that people with HIV, nevertheless, tend to gain more visceral fat than they do in terms of the other fat. What I did not expect to see necessarily was this decline in lean mass, actually, of 2.6%. And that's, I guess, a little surprising, but I don't think that this was necessarily an older population. So I'm not sure if that is something necessarily real, but it's something I think to look at with time. And in terms of on the DEXA scan, about 82% increase in visceral fat, which is quite a bit. What was and so the table here actually looks more specifically at separating the individual arms. So the dolutegravir 3TC arm here, and then the BIC FTC arm here. And the only thing that was statistically significant in terms of a change from baseline was in total mass, which was statistically significant, as well as appendicular fat mass, which I don't know. I'm not that sure what to make of that per se. I think we know that and this was a switch study, so it is interesting that maybe people do gain a bit more fat even with the switch study. So these are people that are well controlled. But I think most significant is this increase in visceral fat that was seen, and this was statistically significant, and whether it was either arm. The study on the right was mainly looking at liver fat, basically suggesting that the changes in proportion of people living with HIV with steatotic liver disease, maybe there's a slight increase, perhaps a trend over time. But I think we need to keep in mind that whenever you have visceral fat, it is also a marker for fat in other locations. So that means fat in the liver, fat in the heart, fat in other locations as well, too. Um,
Then,
so
did you see the question? Did they mention
yes.
any changes to bone density on the DEXA scans?
Yeah, they actually did not on this. They really just kind of focused on the more the fat aspect. So no, unfortunately, Edie, they did not. Although I don't I don't know. I'd probably have to. I think you might be able to find the presentation live, but I can follow up on that for you, Edie. The conclusion here was that switching to dolutegravir 3-TC or BIC-F-TAF was associated with a trend towards an increase in the frequency of steatotic liver disease. Overall, no difference existed between the two arms, but that those treated with BIC-F-TAF showed an greater increase in the frequency of steatotic liver disease compared to those with dolutegravir 3-TC. All right. So I'm going to show you very briefly two switch studies looking at doravirine islatravir. And I see Robert said, keeping in mind your point about what people switch from, it does seem that switching to TAF did cause more weight gain than regimens without TAF. Yes, perhaps. Uh, I think that's really kind of the question. We'll talk about some of perhaps the mechanisms in a little bit, but I think it's still, I don't know. I think there is data suggesting perhaps that is the case. Um, I'm going to talk a little bit about the switch study to doravirine islatravir from BIC-F-TAF. And the reason I'm kind of mentioning this is because doravirine islatravir, if this comes out, maybe could be a candidate medication, even though the studies do not suggest and the guidelines do not suggest that we should be switching people to a different regimen for weight gain. The practical side of things is that our patients do ask about switching, to something else. So this may actually be an interesting candidate, perhaps to switch to. And so islatravir, if you remember, is an NRTTI, so a nucleoside reverse transcriptase translocation inhibitor with doravirine. And so the initial studies were notable, I think, for this decline in lymphocyte and CD4 cell counts with the higher dose of 0.75. And so as a result, the Merck had switched to this 0.25 regimen. This is the dose that's been kind of moved forward. Here is the study protocol in terms of looking at people. So with undetectable viral loads on BIC-F-TAF, and basically randomizing them 2-to-1 to either doravirine islatravir. And keep in mind, it's two pills, doravirine islatravir plus a placebo, or it's the BIC-F-TAF with a placebo. So it's two pills, not just one pill a day. And so this was looking out at week 48. I am not going to spend much time in terms of the actual outcome, but essentially this was found to be non-inferior to the standard of care. What I'm going to focus on is really the mean change in weight. And bottom line, at least in this switch study, there was really no significant difference. And there's maybe a slight decrease in the doravirine islatravir weight, a minus you can see here, and a small plus in those who continued on their arm. And the difference was a little bit, 0.3 kilos, but not statistically significant. So at least this study did not show much of a difference. I'll show you, this is a related study. So people were switched also to doravirine islatravir, but in this time from any oral antiretroviral regimen. So they could be on other regimens. And so with that said, kind of a similar in terms of people being randomized to switching or they stayed on their initial antiretroviral regimen, and then eventually people were able to get onto the open label side. But with that said, we do have to keep in mind in what I've kind of in this blue square is looking at what people's antiretroviral regimen was prior to the switch. So there was about maybe a third of people that were on an NNRTI prior to the switch, and also probably about a third that were on TDF prior to the switch. So we would anticipate that these are the people that are more likely to gain weight, perhaps with any switch. So the study itself, the primary outcome was not inferior. As I said, I'm not going to spend time on this. But what they did see, which I think was not necessarily surprising, is that there is weight gain, right? So weight gain, and especially in those people who are on either an efavirenz or TDF at baseline, there was a weight gain. So I think, I don't really expect like doravirine and islatravir to be that metabolically challenging for our patients. And so I think perhaps this is maybe the real effect of removing efavirenz or TDF. But this is ultimately kind of the question. In people who were not on efavirenz or TDF, as you can see, the bars are a bit closer, but still maybe a little bit more in terms of slight weight gain versus those people who stayed on their regimen. So I think that is kind of to be debated. So I'll go ahead and stop, or actually we'll switch gears, and I think time check 8:52. I'll probably just get through the weight gain studies here. There's only just a few left. And so I think semaglutide has been something that a lot of us have been using. And there was this interesting study looking at semaglutide on cognitive function in people with HIV. And so just to kind of back up for a sec, there is this relationship, interestingly, between having more abdominal fat and decreased cognitive function. So the thought is that if you use semaglutide maybe to reduce abdominal size and girth and reducing fat, maybe there's some effect on improving cognitive function. And so that's kind of the background as to why this was done. And the key findings were that the only thing that was found that maybe improved was visual spatial score had perhaps remained statistically significant and maybe some improvement. And so I actually had to look up what visual spatial processing involves. So I put this on the bottom here, is that it involves understanding how objects are arranged in space, the relative positions, and how they may change if manipulated. So deficits can impact skills such as reading, math, navigation, fine motor skills. So this was the only thing that was found, at least in terms of cognitive function, that seemed a bit better. But no other correlations were observed in terms of the change in cognition scores on semaglutide and changes in total or central adiposity. And then lastly, I think this is the last study I probably will talk about given time, is about semaglutide and epigenetic aging in people with HIV-associated lipohypertrophy. And this was presented by Michael Corley, who I understand is now here at UCSD. And I'm not sure if he's actually online here, but welcome, Michael, if you are. So just a very quick background. We know that semaglutide reduces visceral fat, promotes weight loss, has a bunch of cardiometabolic outcomes and improving. And so variety is listed here in terms of benefits. And so this was a study that I actually presented a little bit last year by Allison Eckert and Grace McComsey. And so this was a study, a 32-week randomized double-blind placebo-controlled study looking at semaglutide on total and visceral adipose tissue in people with HIV lipohypertrophy. And so this was a secondary analysis looking at the effect on epigenetic aging and biomarkers in people with HIV. And so the hypothesis was that there are pleiotropic effects of semaglutide, just like there are with like statins, and perhaps that might impact aging. And so this was kind of the study protocol. I'll only just note that the dose of the medication was only up to 1 milligram. So it's not necessarily the highest dose. We know the semaglutide you can go up to 2, or with Wegovy up to 2.4 milligrams. So this is kind of a medium dose. And so there were these epigenetic aging clocks that were looked at these intervals. Um, and so I'll try to explain a little bit about these epigenetic clocks. And so the first generation clocks mainly are looking at DNA methylation to try to determine, like on a chronologic level, are people aging, and by how many years. Second generation clocks added more clinical data to look to try to estimate mortality. And then the third generation looks more at longitudinally over time to try to determine the pace of aging. In other words, are people aging at a slightly faster rate or not? And so that's all I'm going to say about these epigenetic clocks. And so what they found at baseline was interesting, is that so these are people with lipohypertrophy. And I would say that people with lipohypertrophy are likely people who have been HIV positive for longer periods of time, which probably suggest higher levels of chronic inflammation cumulatively. And so, based on the first generation clocks, it suggests that at baseline, these are people that maybe are like 3.74 years older chronologically. They're perhaps at 9 years, perhaps higher, faster mortality risk. But interestingly, the pace of aging was essentially 1, which is that they're not necessarily aging faster. And that's at baseline. And so what you can see here, so looking at the semaglutide arms, so the annual rate of change in epigenetic predictor of mortality decrease. So that's here in the second arm. So you can see in the placebo, there are plus numbers, and the semaglutide, they're minus numbers, suggesting that it changes from the 9 years perhaps to a lower number. And that was statistically significant. And also the pace of aging also tended to slow down with semaglutide. So I think these are kind of interesting thoughts. When you also look more specifically at semaglutide, maybe there was about a 3-year decrease in the annual rate of epigenetic aging of mortality that we talked about. And then, at least in terms of the pace of aging, maybe there was about a 9% decrease in the pace of aging. So the bottom line is that it seemed like semaglutide stabilized epigenetic aging in people with HIV-associated lipohypertrophy. And so as you can kind of see, this is kind of the standard line, this dotted line of how chronologic age should also correlate and be equal to biologic aging. And the thought is that with HIV, maybe you increase kind of the biologic age a bit faster than the chronologic age. And the hope is maybe with semaglutide, maybe you bring it back down to more along this chronologic age line. Um, so I think I'm going to go ahead and stop there just because we are at time, and we can go ahead and just see if there are other questions. I guess I can probably do that other talk another day. But let's see if there are any questions. And I'll look in the chat here. So I see from Nettie, discussion thought, not for today. Should we be using more TDF? Compared to osteoporotic fractures, obesity, hyperlipidemia, diabetes, CVD more common. I think that's a challenging question. I think you and I and many of us here have lived through the TDF eras, and I think it's ends up being kind of picking and choosing which toxicities to kind of deal with. I don't know that answer. I mean, I think it's a case by case discussion. I see here in your second point, and INSTI, TAF associated with weight gain, hyperlipidemia are exacerbating these conditions, and I get that as well. Maybe newer ART options will be better, and but so far not. Yes. So I think hard to say. I think that is a case by case, but I certainly have not started using a lot of TDF, and at least at this time. So, Edie, did you have a comment as you're doing your hair? You're on mute. You're still on mute. And still on mute.
There we
you
go. So my question is it more that going on TAF makes you gain weight or going off TDF?
Right. And that is the question. I think definitely it seems like on the studies going off of TAF and efavirenz, I think we can be more assured that people do gain weight. I think the question is to what degree does being on TAF or INSTIs lead to an increase? And I think that is probably variable depending on individual, my guess is characteristics and individual susceptibilities. But those are not things, unfortunately, that we can know upfront before we actually switch people to that. And that's the challenge.
Well, that's why I was asking about the bone density part of that other DEXA study.
Yeah. 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 I don't know.
It's interesting to me that while one thing is taking precedence, they're forgetting about the other part.
Yeah. Yeah. And I think it's always going to be this balancing act, unfortunately. Yeah.
Thanks.
Thank you. And I think, is there one more comment? Okay. Yeah, Robert. Yeah, I can send you this copy of the slides. Definitely. I can do that. So, anything else?
That was brilliant, Dan. Thank you so much.
All right. Have a great weekend. We'll see you next week.
Happy weekend, everyone.